Perfect. So welcome everyone. Good morning, good afternoon, good evening from wherever you are. Thank you so much for joining us today. So this is the ISUH African Urban Health Community of Practice second webinar. So thank you so much for taking the time to join us. We're very excited to bring you this webinar today. Just as a brief reminder, in terms of meeting hygiene, please feel free to put on your cameras. Please mute yourself unless talking. We have a good lineup of guests, speakers today, and we're looking forward to getting into that. As a reminder, the Africa Action Group of the International Society of Urban Health, we bring together scholarly governments, non-governmental, private sector, community actors, local actors, advocates in Africa, on the continent, to really exchange knowledge and practices to advance urban health and promote health equity in the region. So it's very much looking forward to a great discussion. And some of the things we're trying to do is to really connect urban health expertise, not just expertise, but demand across the continent to really to encourage that transdisciplinary research partnerships between cities, between countries, between actors. And what we try to do is really share information about relevant regional events, such as conferences, seminars related to urban health. And these spaces really act as that. So we really try and design these spaces for the community and for the community of practice. So you'll see we have a website. We have a newsletter, so please sign up to that. And we really want to also try and share training opportunities, including online and in-person short courses, scholarships, fellowships, opportunities. And I think there'll be more on that towards the end. And we share proposals, webinars, other ways to mobilize the community. And we really try and regularly evaluate the impact of the work we do and the group itself to see what's really useful for the community of practice. So you will see from the website, there's a little bit of an update from the last webinar we had, so please do look at that. There's a whole host of resources which were shared after the last webinar, and we're looking forward to having more after this webinar. So I will just briefly introduce our speakers today. Today we have 3 speakers who will go into the ins and outs of urban governance from the health perspective. We have Dr. Remy Sietchiping from UN Habitat, who will lead us off in talking really about urban governance tools and some of the theory behind that. Then we have Dr. Mohsine Bouya, an advisor to the governor of Berkane province in Morocco, who will look into some of the practical sides using data and GIS to promote and support urban health governance. And then we have Ms. Ivy Chumo from the African Population and Health Research Center to give some experience from the research perspective on urban governance and some of the community-based research approaches to governance. So I'll let the speakers introduce themselves as we start, but perhaps we start with Remy for the first presentation. Remy, over to you.
Thanks a lot, Charles. Yeah, I think you can hear me now, hope. Thanks a lot. Hi, friends, colleagues. Yes, my name is Remy Sietchiping from UN Habitat headquarters in Nairobi, where we work on a range of issues with the ultimate hope and aim to actually impact the quality of life of people, especially those in the city. And that's why we are here today to share with you some ideas and how we are trying to address some of these issues to achieve such outcome. I'll be assisted with my dear colleague Leandri, who would be sharing some of the few points we have put on the slide for just kind of visual support. So what we are trying to do here is to really go from looking at the result, the type of changes we would like to see happening, and some of the means to do so. You'll hear very much in our intervention that we try to, when we talk about health in the urban environment, we are thinking very much about equity, about how actors can actually pull together to make those, to reach out those, that type of outcome, so that no one is left behind. So on the next slide, we're gonna get started, Leandre. The way we're gonna do it, we're gonna also try to make this session also interactive, where you can engage. So feel free to, scan the QR code to follow the instructions. I mean, follow the presentations and contribute to some of the small polls and quiz that we're gonna have throughout the session. It will be just 30-second quizzes that will help us move ahead. I hope you have seen. You can either scan the QR code or just go on the website at slides.com/SO826. So I think some of you who are here may have already got that. So you can move Leandre. Okay, just to put the context, why urban matters, and later on why urban health matters. We know that the world is very much urban and the trend is continuing. We know that there's this a big imbalance, a big gap, especially in terms of access. If you talk or consider some of the amenities or some of the things that sustain anyone, like access to water, there's a big discrepancy there. We also know that there's an increase, especially in the urban settings. Some of the features that you see there is the air pollution, which is more concentrated there. That would be part of the non-communicable disease we're going to talk about later. The issue of movement, how do you move around? So the issue of mobility creates some externalities that are in the health sector, and we need to consider that. And that it's very important that we keep some of these elements in really at the heart, knowing that the concentration of people also creates externalities. But the good news is that there are many ways we can address them as well. On the next slide, Leandre. So you can also get the link from the chat. Leandre has shared that in the chat. Okay. So with that context of ensuring that we try to ensure that we try to give equal opportunity to everyone to change, improve the quality of life in the urban setting, what would urban health means for you? Okay, so some of you are already contributing well-being, and if you can agree on the same word, you can also select the same, and so that we can see if
okay, I'm sending
which one is
forwarding them to UNOPS, but can you please? You shared already? No.
Okay, so we have well-being, dignity, equity, inclusiveness, proximity, community involvement, safety, dignity. It's about opportunity. So different ideas that can enrich that discussion and why it matters. And we see that well-being and equity are really important issues so far that you have identified as the why we should be interested in the urban health in general. So equity, well-being are important. Maybe we can get moving, Leandre, so that you can see that some of these contributions are indeed very much at the center of what we just said. So the issue of well-being is at the center of that. And because urban health is about health in a specific setting, which is urban. So the physical dimension, the spatial dimension is very important. And that what can contribute or impact on the people living in the concentrated settlement is very important to improve well-being, as we discussed. And you have had identified earlier on in terms of what it means in terms of urban health. So on the next slide, Leandre. So again, as I said, it's really about the spatial component. It's not necessarily the health as you understand as personal, individual health, but the collective health. That's why public health is very important. It's about looking at that, the urban setting, and ask ourselves what type of resources we have, what type of land or area where we are living. Is it conducive for a better health or not? Is it the way we organize our space? Is it good or not? The way we move around, the type of conditions that can improve our health outcome, mental, physical, and others such as green spaces, blue spaces, open spaces, all those that could be contributors. And when it talks of collective health, is it about promoting health of that environment and the people who live around in that environment? Are the services that we are using or have access to helping or not? So that in the end, we not only improve physical health, but mental health and equity, health equity, giving opportunity, chances to everyone living in that space. On the next slide, laundry. And we have seen as we move to the next slide that this discussion is taking place when we are still, battling with COVID, and this is very much at the forefront. We have seen that it was a public health issue. As I said, we wanted to use the narrative of air pollution, which cuts across maybe an urban area that creates kind of that externality that is equitable, because everyone is exposed, who is out there is exposed to the air quality or air pollution. But now, how do we actually deal with that? The way we set up, the way we promote some of the activities or promote some of the lifestyle can actually impact at the individual level. The issue of obesity being one of them, and some of the non-communicable diseases are concentrated in cities. You can talk about, I don't know, heart disease, all these type of diseases that are not necessarily communicable are very much in cities based on the lifestyle. We also know that when the concentration of mobility in cities can cause also externalities. The same for other issues that we will not find the same thing in areas with less concentrated population like rural areas. And we know that, as I say, we have the backdrop of COVID, that the 90% of cases were in urban areas, and that when you talk about poor air quality, is very much concentrated again in urban settings. Next slide. Then, so when you have so many actors engaging in addressing, because it's not only a clinical issue, it's things about planning, it's about financing, it concerns all of us, all sectors, all actors. So this issue of governance, that's why I say we want to talk very much about the governance of that. It's becoming so essential. How do we work together? How we coordinate the action so that we are not duplicating or competing, so that each actor can be, have a clear roadmap, clear idea of where they are contributing. And that when it comes to mobility, mobility is not only those involved in the transport sector, it's about those who plan the cities, those who manage, those who, even the taxation, what type of vehicle can be, approved to run in the cities, how you do. So a large range of actors who get there. And of course, the community had to be aware of their contribution and how they can make a difference, contribute to improve the quality. And we, as a matter of fact, the equity is so important. So we have to look at those who are the fringe, those who are vulnerable. I was listening, I think it was a BBC report that I read, which was saying, some people are more concerned about feeding themselves than be exposed. I think it was a study done in India that it's the most polluted cities, but the problem is that they have more immediate issues. They are not even concerned or aware. So that some of the things can start with just awareness, so that they can take some measures to reduce. Of course, it's very important that we invest in ensuring we have some evidence to support that, because it's not only about gut feeling, it's about making sure that we have something to back that up. We know finance matter. If you have the economy of urban health, people can start paying attention. Policymakers pay attention when they see the bottom line. So again, in terms of infrastructure services, then they have to be commensurable with the type of urban health responses that can be provided for the benefit of all. Now you can move into the to the next slide, Laundry, where we just a reminder for you, if you were to choose what to reflect the equity. Is it when you have the hello? Okay. So the equity, how would you define it? Is it something that we have the same start in life, or we have the, you are giving a ladder when you need that? I think we have what? Just 6 responses so far. 12 responses. Many of you giving opportunities to everyone, to each based on the capacity or some of their ability and so forth. And all of you seem to be approving that, which is true, that indeed it's not give $10 to everyone. Some may need less, some may need more. So very important that we have to keep that in mind as we talk about equity. And that's why is it related to health? Because it's very important for the governance. How do we try to create that subsidiarity system, for instance, to cushion those who are more vulnerable to some of them, more exposed to some of the health issues in urban settings, so that they can actually achieve or leverage on the potential opportunities that will be given to them, and that they are not further disenfranchised by the conditions they find themselves in. So again, through that you can, governance is very important. We are focused here on the equity dimension, but through that you can also talk about other dimensions of governance, which are very much pertinent when we talk about health. If you talk about accountability, I talk about subsidiarity earlier, I talk about empowerment of those who might need help. It's about engaging, community engagement, participation. It's thinking about being inclusive so that no space is left behind, so that we can all really move ahead. I can see that you are all approving that this is the way we should be looking at urban health, and why governance matters a lot to create more equilibrium, a more continuum in engaging with for the benefit of all. As you move to the next slide, we think that some of the principles of governance that apply very much in the urban setting is, especially in the context of the sustainable development goals, is to make sure that we have some policy coherence. As I say, health touches on so many sectors in the urban setting that policy dialogue, continuum, coherence is very much important. We already know that health might be sitting in the social pillar, but economic of health matters, environment under which health operates is very much essential to achieve a better urban health outcome. And it's all about people. So getting that community, getting people engaged, knowing what they have to do, or what their contribution, or what they can achieve through their own engagement for the interest of all is also very important. So when social services actual investment in social services and infrastructure in the health sector keeps equity in mind, meaning that they put the services infrastructure where there is a high demand, when there's a high need, when there is less ability to respond. And of course, we have to keep on the check all those changes that are happening. Yesterday, realities may actually evolve where we can be facing different challenges today. So just keeping that in mind is very much important, because it's urban health is very dynamic. Urban system is very dynamic as well. Next, Leandre. Now, as I said in the last part, that is very good to monitor. So you can monitor the governance dimension in many ways. And there are, we just produced something on leveraging multi-level governance approaches for health equity. That meaning that we are focusing on the equity and how we can work together, all work together to do so. And through that, we have different ways you can do that, different roles that actors can play to make that difference in their own capacity. And there are some checklists or some elements you can just use to check. And now I'm talking about the tools, as some of I was asked to cover, and how do we make the health equity, urban health equity works. And that's one of the instruments, one of the tools we have pulled together to help out with that. Anyone interested in that, we have a link at the end where you can access. Or the next one. Next, okay. So we also think that you can think of the high level achievement and principle to guide you. If you just turn this into a quick checklist and say, okay, when I'm talking about urban health, how open am I to engage other partners, other actors, other stakeholders is very important. And here we are talking about network of actors. It's not only, later on I will mention that it's not only about government or from national to local. It's about the health sector, about the private sector, it's about the community health workers and all those actors that are from within the context of urban health. And we have to localize so that you can see the difference, what is happening really at the local level. Though urban area is vast, but you have to start having the possibility to say these are the changes that are happening in this environment. And since urban is dynamic, what is urban to rural tomorrow might become urban. So we have to be able to anticipate and also cushion those who living in those areas so that they are not further affected by, urban-driven health challenges. And it's important that we look at the equity, even from the gender perspective, from the youth perspective, from some of the groups, and just saying it's not the same for everyone. Some may need special needs, some may need, in terms of health responses, we should also be aware of that. So some of these quick things may help us in terms of broadening our principle and how we can engage in urban health for the benefit of all. On the next slide, Landry, we are almost getting to the end. I think we have, okay. We just put this one because, as we have noted during the COVID pandemic, the role of local government has become so central because the local authorities, regional authorities, at times did not see health as something of a concern to them. But the COVID, that was a global, crisis, health crisis, had actually brought to fore the role of what local authorities, mayors, and others can do. So, but they couldn't do that alone. And that was a good example of how we can work as multiple actors, including private firm, international pharmaceutical, all these things to actually bringing collective response. So in the report we produced last year on cities and pandemics and what type of responses were brought in, and in this discussion and in the next I will share with you some of the findings that are very much pertinent for anyone working on urban health and how actors, the role of actors could be further optimized. Next. Leandre? Okay. So we have already said about the multi-level governance, which is about the network of governance, and no one should work alone in the urban health sector. And then we have, for anyone interested in the guide, look into that as well. Let's move to the next one, Leandre. Another resource that we have is about how do we use technology to actually have an idea what is happening out there. The digital governance or the digital health had been very critical during the pandemic and other actors, and many of you have used the apps in your country, your context, in the context of the pandemic as well. So it's more likely that the governance of health had to be sometimes more digitized in the future, where we're going to talk about more e-health than others. As you know, the penetration of RCT technologies and other in cities is usually much stronger than other segments. Next one, Leandre. Okay. Of course, what can help others are actually looking at what other actor had done. So we have put together a compendium of different cases of how planning could actually help address urban health in general. So a range of cases that look at collaboration, that look at power relations, that look at really the impact of health using planning as an intervention, and also urban health in terms of policies, how policies are more agile, flexible, and health responsive. Because in some of the urban policy, as you may imagine, sometimes health is very silent or sometimes absent issue. But we had noticed that urban policies that look at higher outcomes like the well-being and health for the environment and people that live in have the better chance of actually making significant difference in people's life. The next slide. So just to give you an example of the tools or some of the case studies that could be of relevance is that one here in Kenya, where we documented the issue of water, because as I say, the equity, how do we access, just a caveat that that people living in deprived neighborhoods usually pay more for water, sometimes energy and others. So they have additional burden. So this particular intervention would help in achieving many things, not only creating more equity, but also having impact on the quality of the food or the access to clean water, drinking, and diarrhea, other type of diseases. So multiple benefits in such interventions as well. And this is happening. It can happen at the municipality level. The next example is a much larger scale, metropolitan, I think, where in Lagos, they are looking at, again, the ultimate outcome I mentioned earlier about well-being is about how do you bring everyone, pull those who are suffering in a situation to alleviate some of their pain. And this is very much in line with the context of what SDG had been promoting, leaving no one behind, and that covering everyone living in the metropolitan area of Lagos has been a good approach. That is, yes, local contacts matter, but in the metropolitan area of Lagos, that also a local context. Next slide. Now we have to just quickly, if I were to check so far, if I was not just talking to myself, what for you are the key elements that should be taken into consideration when you talk about health governance in your city? Okay. One concern, corruption. How do you engage multi actors, multi-stakeholder? How do you make that work? The issue of equity is still a challenge in your city. Yes, collaboration is not easy. What had been tried, maybe couldn't work or fail, so that we can learn from that. How do you make sure that all these multi-stakeholders participate? Again, the collaboration, how do you make that work? I think in my presentation, there are some suggestions in the health equity guide on how that can be done. How do you gather and manage the evidence to inform the decision? How to align health governance with urban and climate priorities? I understand is a big competing priorities. Again, the issue of data. How do you make sure that the quality, minority or vulnerable group are supported? On the next vote, Leandre, yes, so that we can see more. Again, you can choose. You can, if you approve or agree with some of the suggestions, feel free to just select, to just put your thumbs up so that we see which ones seem to be maybe common in many cities or those who are attending. That the multi-stakeholder approach is of interest to some of you. The issue of corruption, how to deal with that. The issue of equity, indeed, is very important. How do we cover urban health indicators at neighborhood level is something that you are interested in. What had worked or failed in the past. I think that's why we developed compendium of inspiring practices. So yes, some of you had actually identified or relate to what had been proposed by some colleagues. Leandre, cross-sector collaboration had also been noted. Shall we move, Leandre? Thank you. Okay, so since you are interested very much even in the last response on the how, we have pulled together some here that may help you in terms of how do you do that. We have, as I said, the cities and pandemic report that we produced last year have many example cases and tools. The work that we have done with WHO on how planning, urban and territorial planning can help addressing urban challenges, that contribute to better urban health outcome is also a good source book. We call it source book that you can use. We already covered the guide on multi-level governance approaches, and I saw you have all expressed interest. So feel free to have a glance through that publication to see how you work with different actors to achieve some common urban health outcome. As I said, if you are interested in some examples, there's a compendium and many other that other partner will have produced. So thanks a lot, Charles, for this opportunity. Thanks, colleagues. Thanks, Leandre, to share a little bit what we have been doing and how it's so central for UN Habitat to consider equity governance when we are talking about urban health. Over to you.
Thank you so much for that, Remy. I think that was a brilliant, great interactive overview and introduction to governance in the context of urban health, and really starts to give us some ideas around tools and guiding principles to think about, particularly when we're trying to promote some of these key issues, and definitely thinking about the multifaceted nature of the challenge. And I think it really ties on nicely to our next speaker, Dr. Bouya, who's going to go over some of the some ideas on how to use technology and data to support urban health governance. So Dr. Bouya, I'll hand it over to you, but just to say to participants, any questions, please put them in the chat and we'll get to the Q&A once all the speakers have had their interventions. So Dr. Bouya, over to you.
Okay, thank you very much, Berkane, for the invitation. of the governor of Berkane to share the experience of this province regarding using technologies for urban health governance. So let me share all of slides. So I will speak about 3 axes developed by Berkane province. The first one is about vision. What is the vision of Berkane to master the management of this area of health? The second, using tools, what we call geo-governance, to manage health and not only. And after I will finish with the materialization and with some applications developed for COVID-19. So you have to know that all the Berkane experience starts from the speech of His Majesty King Mohammed VI regarding the development regarding the human development with a new strategy called Phase 3, with a focus on human development with health like a big need to develop humans and wellness of society generally. So let me go to for this initiative called the Moroccan NDH initiative. It developed four programs. We developed 4 programs for this initiative, and 3 programs, 1, 2, and 4, target to develop health and society wellness. Berkane, you have to know that Berkane is a northeast province in Morocco with more than 300,000 people, with the covered area almost 2,000 kilometers square, with 6 urban communities and 10 rural communities. And for this province is characterized by a big community of youth. The economy is developed on agriculture and tourism pillars. And so Berkane province is now like a model of Morocco for technology, for IT or digital, the using of digital for governance. And also we speak now about the integration of digital tools to plan and to schedule all the projects in this area. So concerning the vision of the governor, this is like a history. The history starts from 2018 with the creation of a provincial committee chaired by the governor. This committee, in this committee, they have all actors for health and social sector, and they develop like what we call gubernatorial order to create this committee and to develop a global strategy for the all health sector and social sector in Berkane. This is the starting point. After that, they create an association for the support of the health and social sector, known as APHRC. And this association is, and now all the health and social sector are managed under this umbrella of the association with the all actors. So the first point with this, the first zone of the association was to start a diagnosis of the state of the health sector during the first year. After that, the association established an action plan to support the health sector. This plan was discussed by the Prevention Committee and validated by all the actors. And after the third axe is the identification of the main lines or areas of work of the association. Here you see the 11 axes developed by developed by the association. We have mother and child, biological analysis, reduction of appointment times, and so on for appointments for doctors and so on. So for this 11 lines or axes, I will focus only on three axes just to show you different achievements by axes. You have to know for the pillar of human development in Morocco for this phase 3, the focus on health is about mother and child. So in Berkane, they launched a general census in the province, door-to-door census, to have a global data about childbearing, women of childbearing age and children, also housing conditions and living conditions, chronic disease, disability, and schooling. It is really a huge work which is a digital, all digital process, census work. So they done a lot of other achievements, like equipments of a neonatal unit in the pediatric department, fitting out and equipments the parent class, a new concept in Berkane that we consider parent class and not only mother class. Programming the purchase of mammography equipments for breast cancer screen and fight against malnutrition in children. So this is this axe is like the focus right now in Berkane, and they exist other achievements for biological analysis axis that you have to know. For example, in Berkane, by using a new process that we reduce the appointment of doctors from 6 months to 3 days, which is really a big achievement. For therapeutic support at home, yeah, it exists in Berkane. And right now, the more than 1.5 people taken care of, including 50% in hospital beds. Let me speak about the acts of fight against adicotology and help the reintegration and prevent during addiction. Now they have really the open addictology center, which is the first one in the Oriental region, which is a big achievement also by this methodology and the vision of the governor. So this is concerning the vision, which is aligned with Moroccan vision and Moroccan initiative. And now let me go to do GeoGovernance. The vision of GeoGovernance in Berkane is for sovereignty of public health case of Berkane city, Morocco, which is very important. I will show with you some examples. So you know that people, place, and health is very linked. We have a strong. Location, almost everything that happens somewhere, now we can identify and geolocalize all what we need by using what we call integrated model of geography. So concerning public health, you know that that this tool is very important to link the physical to physical state with social and emotional well-being of residents. This is the focus concerning the public health. And for that, I will show you some examples on that. Maybe you are already, you have a basis in this type of geographic information systems, which is a tool that we can find a lot of layers. In Berkane, they develop more than 400 layers of data. And we can visualize all of this data regarding the space of the territory. And also we can do the analysis, the data analysis, and now more than that. So here you see that, for example, in SIG now, GIS, we can identify all peoples for each area. With here at right, you have the colors for the density of people, and at left you have the number of inhabitants with regarding the density also. So this is like a fundamental data to manage the territory, that you know the density, and you can after that develop also the strategy to answer the population needs. So here you see, for example, this is a GIS data. This is like basic health facilities, health centers, dispensaries, all classes, public, private, medical staff. So all of this information are known, and physical layers are matched with software layers. And you can see, for example, different centers of health, hospitals, and how about the closest of between, how about the distance between the population or peoples and different infrastructures, which is very important to plan and to schedule the new projects. So here you see, for example, the existing hospital, and with this information, you can see, for example, that we have the at the middle the hospital of Berkane city, which is with a huge density of population, and another one in Saidia. And the plan now regarding this analysis to have the third one at APHRC to answer the proximity and to answer the closest of hospitals to the population. So here you have the proximity of provinces population to health services per kilometer. So here you see that we can, when we see this these graphs, we can adapt the new opening of health centers. Here you have also the information that we extract from the SIG. So with a focus also for motherhood, which is very important also, that you know that for health now the mother and child is the focus, and of that now we can at Berkane by using this strategy, they reduce the number of deaths of new baby by identification and opening for new motherhoods. So the same that you have also different data that we can analyze and identify also in urban and in rural areas to answer the health needs of the population. So here the same about the smart management of territory by using the GeoGovernance. And let me see that which is important here in this example, in the example at your right hand, we see that we monitor also the psychological disorders also in the society, which is very important also, that we can also use this data, for example, to understand why in each regions we have a concentration of these psychological disorders, for example. Yeah, so for that, after having this type of data and the analyzing of this data, that they develop a new, what we call a new index in the territory called the Index of Territory Disparity. This index is it's very important. With they use a score from 1 to 10, for example. For this is like a priority of different spatial and environmental dimensions, and with 14 indicators. So with this IDT, that now we can have two maps. The socio-economic component maps by using different indicators, and also the spatio-environmental components, also that we can also master our environments, and you have to know also that they are targeting to develop a strategy according with ODD with ODDs to leverage some sectors of the territory. Here you have different goals, for example, and the population that we target with this index, and so this IDT is really very important, so that we can have a global idea about the territory needs, and also to develop social and environmental consideration. Let me now move to the very strong point in Berkane is the dematerialization. The objective is reconciling efficiency and transparency to achieve social equity. For this target, that they plan a lot of they have a lot of programs for dematerialization, and you have to know that at Berkane it exists the first administration area, full digital administration area, that we, for example, for all administration work or administration needs from the population, which is really very big achievement in Berkane. Let me show you some applications for COVID-19, so that Berkane was really in the first or the top pool in Morocco in terms of COVID management by using geolocalization and the remote medical monitoring platform. That, for example, for this application, we can identify suspect persons affected by the disease and to monitor their health status and so on. The same, they developed also applications to allow clinical monitoring of suspected cases and their contact either at the hospital, inside the hospital, in case of home confinement, and other application to geographical map integrated in the solution represents the different cases of COVID-19, which are displayed different colors. And for each color, you can have the global information of the state of disease, COVID disease in Berkane. And so for this application was very useful for the management of disease. The same here, you have a lot of examples by using this geographical systems to manage the COVID-19. Okay, so this is what I was to share with you, and we are really open for questions and for more explanation.
Thank you so much for that. I think that was a really fascinating insight as to how to use data and GIS techniques and how that can be applied to an overall vision and mission of health within urban settings. And not only sort of how that data is captured, but really captured in a way to answer specific health needs of the population. So I think that was very good. We'll move on to our last speaker, Ms. Chumo, from the African Population Health Research Center. And she's going to give us really the research perspective on urban governance and how community-based research approaches to governance and really how to foster some of that accountability that we've been hearing a little bit about. So Ivy, over to you. You're on mute.
Thanks. Hi, everyone. I am going to present about urban governance, and the most of it is about unpicking power for urban governance, and that's how it happens in the informal settlements or for the urban poor. And the approach that I'm going to take is on participatory action research. And unlike Remy and taking into equity as a component of urban governance, I'm taking the social accountability component. And social accountability is an act of governance. It's also a process and also a value. And for it to action, there has to be more than one party, the supply side and also the demand side. And as you can see in my other part, the demand side, usually the community or the residents would then demand for accountable or demand for services from the service providers. And they would demand for better services, they would demand for affordable services, and they would want justification from the service provider as to why the services are not affordable, the services are not equitable, the services are not cost effective and such, which is usually the shorter accountability route, just the people from the community demanding for services from the providers and looking for a justification. But on the other hand, there's also the longer route of accountability, which is also that component of governance, that the people would take their issues to the policymakers, who would then enforce some rules to the service providers and ask them why the services are not as it should be, and also try to figure out if they are following the rules or the policies that are already there for them to provide justification for the people. So when we do analysis of social accountability, or in most contexts, when you're doing it in research context, we look at it as a triangle, and that's how it happens in the triangle. But it's always important to look at it practically in an oval way, so that we can unpick the powers that exist in the service provider and also from the people and from the policymakers, so that we all have the actors together and discuss about the voice which is coming from the people, the answers or the justification from the service providers, and the laws or rules that comes from the policymakers, because it's from that we're going to have better governance, because everyone is involved from the onset. And we did a study to unpack more about social accountability, which is a component of governance. But we did in 2 informal settlements. And before we embarked on the study, we tried to do an appreciative inquiry, just the way the previous presenter did some part of GIS. So we used some participatory geospatial activities the same way to have the informal settlements into units that would help us to ensure that every unit in the community is represented. Same for this other informal settlement. Before we did the study, we had to do some consultative meetings, which helps to unpack or actually to unpick the power. And so we had meetings with community advisory committees in the informal settlements where we did our study. And from there, they were able to advise, and they linked us as researchers to the community. And they're also able to advise on the best practices on how we are going to, how we could go about the process. Other than that, just the way Remy and the other speaker also mentioned about the need for many actors to be involved, we also identified the influential people in the study sites, and we had several meetings with them to also understand how to go about understanding the different accountability mechanisms and issues that exist in the informal settlements. And it's from these consultative meetings that we got to understand the need to do some more sensitization meetings. And from that, we went to do some more outreaches or sensitization meetings through community outreaches, and also through school outreaches. Yeah, and it's from this that the message went further to our study communities that we need, and that's how we picked the issues that we could take up in understanding governance, and also we could understand more actors that were relevant or important, and also powerful and also influential to the study. And for that, the first step that we did was to actually, it's from these preliminary activities that helped us to do our research and not be like helicopter research that does go to the community and just pick the things they need and leave the community. So you can imagine if somebody would get into your community or your home or even your workplace and get into the kitchen, get into the washroom, get into the kitchen, and later on they say you're offering poor services or you're poor or such things. So it might be that they did not open the store to find out many more things that you have, or maybe you have another room. So we wanted to do those preliminary activities because it helps us to get in touch and also understand the context. And in such way also we are able to identify community research assistants who would help work with the researchers and study participants, and they are better placed to understand the context or the phenomena in the study communities. So these community research assistants are from the study sites, and they're able to interpret some issues that maybe researchers might have difficulties in interpreting, and also they're able to help the study participants understand some issues better than how a researcher would explain to the study participants. So the first step that we did was community profiling in the attempt to understand about the governance. And this is appreciative inquiry, and it's more using a participatory GIS to understand the basic amenities in the community from health services, water amenities, sanitation, education, and all the other amenities that are of interest to the community members. And thereafter discussing about the equity and how the community are accountable to them and so forth. But more so, there was a need to do ground truthing to confirm those points. Once we did the community profiling to appreciate the resources that exist in the community. We went ahead to do the governance diaries, which is ethnographic approach. And for this, we visited the service providers and also the users for a period of 4 months to identify the social accountability mechanisms that exist. And it's usually a basket of methods, and these are the methods that we used. We had observations, reflections, participant diaries, and informal discussions, and the in-depth interviews. And we did this for 4 months, and from that we were able to identify social accountability mechanisms that are informal and also the formal, but most of interest to us, we went ahead to study more about the informal social accountability mechanism. And once we completed that phase and identified with the social accountability mechanisms, we had several co-production meetings and ensure that we represented the whole communities that we worked with. And it's from this that we were able to create some more knowledge from a vast participant or a vast group of population, including now more service providers and also more users. And for this co-production, we came up to understand more social accountability mechanisms from diverse, or rather a bigger group of study participants. And that means we ended up adding some more social accountability mechanisms. After co-production, we went ahead to do pocket voting because we could not understand all the social accountability mechanisms that we had. It was a very long list, so we had to do pocket voting or pocket listing, and these are the pockets that citizens or service providers and community users were able to pick the best social accountability mechanisms that they felt were helpful in ensuring that the services were available to the community and also were affordable, and the ones that they felt would help in ensuring they have equitable and be comfortable with the service providers using those mechanisms. But at the same time, apart from us voting or having the best social accountability mechanisms, it was enabling us to prioritize the ones that could go forward to the next step. And that next step was scorecards. We went ahead to score those best social accountability mechanisms, and not just scoring, but also giving reasons and remarks for each of those social accountability mechanisms so that it could justify the one that could go also to the next step. But more than that, we were also able to understand the issues underlying those social accountability mechanisms, and we tried to find the way of addressing them. And from the ones that came from scores and got the highest scores with good justification, we went ahead to do some interpretive to give more in-depth analysis and also discussion through collaborative meetings, as you can see. But apart from just interpreting and having evaluating them, it was a way of validating those few social accountability mechanisms that the service providers and the community felt would be useful to them. And once we identified with them and we were able to validate, and we moved to the next step of co-learning, whereby those service providers and users who had adopted the mechanisms for a long time were able to give some learning or share their experiences and share their processes with the others. And these are some of the informal social accountability mechanisms that went ahead to the last step of co-learning. And there were discretionary actions, norms and values, and facilitative behaviors. And all in all, there's hope through social accountability, because water could be availed even from the government authorities, and it could be available in the urban poor communities. And also there's also hope for sanitation, and even children can have access to better sanitation facilities. But also there's hope even for hygiene, and children can have access to hygiene facilities or hand hygiene. Thanks so much. These are the people that helped this work go well. And yeah, thanks.
Thank you so much for that, Ivy. I think that was a good overview, and it really sort of hits home that social accountability is really more than one thing. It's really a process and not just sort of endpoint to a system, and really highlights how everyone governs each other. And it was good to see that sort of community playing a part in that research, and it really goes to the heart what we're trying to promote in this community of practice. And good to see those co-learning, co-production approaches. So now I will open the floor for Q&As. I'll like the speakers to come back on camera, and then we can get some questions from the group. And then before we go into the next part, which is the breakout sessions. So I see there's already one question in the chat for Dr. Bouya. Dr. Bouya, I don't know if you want to, if you've seen the chat. Essentially, the question is around how the province handles very sensitive health data in relation to data privacy, and what are the guidelines and regulations you use around that? Dr. Bouya, are you online? Perhaps we've lost connection, but if there are any other questions, please, please jump in. Perhaps I take the chair's prerogative and start with a question to Remy. Remy, you talked about one of the phrases that I liked from your presentation was the phrase, "No one should work alone in the urban health sector." And so what are some of the complexities, particularly thinking about equity with these multiple stakeholders? There is how we think about equity towards health, but every stakeholder will have their own concepts on equity. So how is that, what are some of the tools we can use to try and build that into the system?
Mm-hmm. I think just straight to the point, you might be aware that in some countries, okay, let's say at the municipal level, at times we don't have a health council. We can have some council or some committee or some form of a meeting of a meetings a platform in other sectors, but not on health. We have seen the same on food, where it's seen as a, for specialists. You can't talk about that if you are not. So I think putting such multi-level is creating that space first for those actors to meet. And the reason, because when you, and we mentioned earlier, we need evidence. If you can demonstrate how health is connected to education, is connected to the financing of the city, is connected to the type of environment, the type of design, you will see that it connects everything and everyone. So that type of thing, but there's no, one of the challenges is that there's no one obvious lead. Because if that comes from the health sector, you're going to see it's about personal health or physician, clinical type of health, rather than the environment and the people in a community type of health. So there are still some challenges, but one of the things, as I said, is to create that space where those actors can come and engage, and second, to find, to create evidence where they can all relate to that issue of health. And we know that even from the GIS, from the when we start identifying the issue of was it the plague or something like that in the UK, it was from the world. If they have not actually, that's where the GIS came from, in fact, because they could locate the source that impacts the whole city. And so it was not from a medical solution, it came from spatial specialists. So that type of evidence can help a lot. That's what I would say for now. As you have seen during the COVID, that it was not only the health people speaking, you know, there were politicians speaking about that. There were people from all walks of life, even community. What can they do to address some of these things? That's what I would say for now, Charles.
Great, thank you for that. Yeah. Are there any other questions?
Yes.
Blessing, please go ahead.
Yeah, well, I think I put it in the chat. I was wondering whether we can speak a little more, expatiate on those three dimensions, three accountability mechanisms that came top. So I think she kind of flew over it, but I thought that was I was looking forward to that meet being shared. Thanks.
Ivy, that was a question to you. Over to you.
Okay, thanks, Blessing, and thanks all. I went through it a little bit fast because I was asked to speak about the methods most, but I can just look at it a little bit. So this informal social accountability mechanisms came out as one of the ways of unpicking power for urban governance. And what was so standing out for the urban poor, for both the service providers and the users, is that most of formal accountability mechanisms like citizen scorecards and some participatory activities that are a bit formal are not usually working totally in silos. So they appreciate the fact that there are existing informal social accountability mechanisms, and that's why they identified with the three. And the first one is discretionary actions. And these were actions that the service providers and also the users appreciate the fact that informally they would reward the service providers who would offer the best services, such that if, for example, they are doing their water vendors, for instance, they would offer to provide them with food if they have a food, if they find somewhere next to a hotel, they would buy food for that water vendor so that they could continue providing water services even during lunchtime. And same case for the sanctions. It came out that, for instance, in a health facility, though I gave out examples from the WASH context, but even in a health facility, the health facility that's private and the service providers talking badly, or they have they're harsh to the patients, they end up having no patients at all in the long run. And it was same for even toilet facilities or sanitation facilities, or even education facilities, or even water facilities. So there could be some water points, but no one would go to buy water from those water points because they either demand for high pay or cost, or they either talk harshly to the users. And also the interpretation of rules and guidelines was a discretionary action, that if the service provider was doing their work well, they would interpret the rules and bend the rules a little bit to accommodate the service provider. So they would allow the service provider to open their water points a little bit late because and not complain to their bosses or to the owners of that water point, because the provider went for longer hours the previous day. So they would interpret the policies and sometimes even bend policies depending on if the service provider is doing their work well or not. And same case for the service provider, they would bend the rules to accommodate and open for longer hours. Even if the opening hours ends at maybe 5 p.m., they would go even up to 6 p.m. to accommodate some people who've gone to work or such. And other than the actions, there were also norms and values that came out from that whole process. And respect was so key, that a service provider who is respectful would also get more clients or customers, or would also be respected by the users. And same case for the users. The user who would come and the word they used was the one who would come and humble themselves. They would even get the services much faster and even easier compared to a user who would come and talk harshly to the provider and such. And value needs was also key, that if the service provider would value the needs of the residents, and the residents also value the needs of the service provider, then it would be easier to have services in the urban poor. And also trust was also key. And depending on how you trust the service provider, you could even leave your containers and pick water later in the evening, or even take water on credit, or go to the health facility on credit, because of trust that exists between the user and the user and the service provider. Same case for some facilitative behaviors. The sustained communication, that the communication that exists between the users and the service provider would then steer up the governance through social accountability mechanism. So where there was sustained communication, and for instance, the community would get to understand that the services are not open because of some few reasons or such, or you'd find at some point at the service provider's point, they have a phone number or an email address so that you could communicate on anything. And also same for complaints and reports. There were some points or some service providers who would indicate some phone numbers where somebody could complain, and they would also open up on some days to allow for anyone who had complaints to come and report, and that would then improve the services. Same case for reliability. Those service providers who would open their points, say maybe water points or health facilities as they are needed, then they were more reliable, and the users would then go there knowing that they would get the services when they needed. For credibility, the word could go around the community about the service providers who are credible, and the ones who acknowledged or appreciated credibility and offered their best would get more clients, would have so that's the end. Thanks. I hope it's clear now.
Perfect. Thank you so much for that clarification. I don't know if there are any more questions. If not, I can hand over to my colleague Amy for the second part of today's discussions, where we go into breakout groups. So Amy, over to you.
Great. Hello, everyone. We have just had fantastic presentations, so thank you again to our speakers. We will be breaking into smaller groups. Gina will assign us to all of these, 4 breakout rooms. And during these breakout teams, there are 2 main objectives that we are hoping to do. The first one is that these are just opportunities for you all to connect. We understand that particularly during this COVID era, sometimes a lot of our conversations are limited to online meetings, which don't often have a networking capacity. So we've built this in, and so during these breakout rooms, we just want to encourage you to introduce yourselves, speak about your interests and your activities and how they relate to this. But then also we have a Jamboard available, which is an interactive online tool. And Gina will share the link with you, where you will just spend time within your groups answering 3 broad questions. And just pop your answers on the little sticky notes there. And please just be attentive to the fact that everyone will be contributing at once. So it might look a little bit messy at first, but can you just stick to your own sticky notes and not editing or deleting others' points? But yeah, the 3 main questions are written at the top there, and they relate to firstly, are there other aspects of urban governance that haven't been covered in the presentations that you think can, or you know that have been applied or can be considered? The second question is, any examples of how you've seen health integrated into other sectors within government? And then thirdly, with respect to the previous example that you mentioned for question 2, who was involved in the process? For example, were there voices of the youth or other sort of groups represented, and who were excluded voices within this? So that's the overall discussion, and then we'll all come back for a wrap up and then some more updates from the steering committee. So thanks, Gina. I think I've seen you've popped the link there, so please all just open that link that Gina has popped in to the chat. And we have 20 minutes for this. Thank you.